Good evening, everyone, and thanks to Dr. Devas Goyal to give this opportunity. And I have been assigned to talk a little bit about the integration of CDK4 inhibitor in the early breast cancer. Now, this topic is important because presently we have the three drugs CDK4 inhibitors, all approved in the metastatic setting. We have the good experience, and two of these drugs now shifted in the neoadjuvant, in the adjuvant setting also for the management of these patients, especially the high risk HR positive patients. So it becomes very important to understand how to select the patient for this particular group of the drugs and how to give the priority or the importance to the one drug over the other in a given clinical situation. So if we talk about the the risk for the early breast cancer recurrence, we know that 20 to 30% of the early breast cancer, in spite of being the HR positive, HER negative, they have the risk. And these risks are dependent on the biological factors. These risks are dependent on the simple factors like the anatomical, like the tumor size, the nodal presence, and the various other parameters. So we need to identify these patients and try to give them the more treatment in spite of having the HR positivity. Now, this distant recurrence is strongly correlated to the nodal involvement in the diagnosis. More the number of the nodes are being diagnosed, more these patients will keep having the local as well as the distant recurrence also. So obviously for these node positive patient, endocrine therapy in adjuvant setting alone may not be the sufficient enough to prevent their cancer from the recurrence, and they have probably the very high chance of having the recurrence. So current concepts of improving the results in the adjuvant setting in the HR positive patient, we all understand that we try to give them the ovarian function suppression. We try to give them the sequential treatment, tamoxifen followed by aromatase inhibitor, something like that, to go to the 10 years, or even the tamoxifen for 10 years. And the newer approach, which may be like what else we can give for these patients. So this is the way that we can try to improve the results of these patients. Obviously, this is the unmet need, and there are the gaps in the current treatment of the early breast cancer who are at the little bit on the higher side of the risk. Now, the disappointing aspect is that as far as the new drugs are concerned, there is a hardly parallel improvement in this subset of the patient, contrast to the HER positive patient, triple negative patient, BRCA patients, so far similar situation in the HR positive early breast cancer in this particular scenario. So if we go by the clinical trials available of the various CDK4 inhibitors in the adjuvant setting, the palbociclib-based two trials are worthy to mention, that is the PALAS and the Penelope trial, which both failed in the primary endpoint as well as the various secondary endpoints. The trials based on the abemaciclib, that is the Monarch A and the Natalie trial, they have moved advancement in this particular field. And as on today, the Monarch is being approved for this particular indication. Natalie E, that is the Novartis trial of the ribociclib, has also shown the improvement in the invasive disease-free survival. Now, this I am talking cross-trial comparison. I am not giving the direct comparison of the two molecules or the two drugs. So, coming to the Monarch A study, which we all understand, HR positive, HER negative, node positive. Now, the basic difference between the two groups of the trials is that Monarch E basically talks about the nodal positivity. So, simple rule of the thumb, based on the nodal positivity more than 4 or 4, if patient has a 1 to 3, then the other risk factors need to be there to consider the patient for the adjuvant CDK4 inhibitor. So this is a simple trial that once you finish the local treatment, new adjuvant treatment, including the adjuvant treatment based on the chemotherapy, when you go for the adjuvant aromatase inhibitor or equivalent drug like tamoxifen, at that time you add the abemaciclib 150 milligram for 2 years. Now, the primary endpoint of this trial is the invasive disease-free survival and the distant recurrence-free survival, and thus other other efficacy endpoints were taken in this. And if you look at the 5 years data, as far as the primary point is concerned, there is a gradually improvement in the outcome. That means, in spite of giving it only for the 2 years, there is a further subsequently, even when the patients are off treatment, there is the improvement in the primary endpoint. And so is at 5 years, the risk of the distant metastasis continue to decrease beyond the 2 years period of the exposure of the abemaciclib. So that is very, very important to understand that it is not only during the first 2 years when the drug is being exposed that the patients are being benefited. It is their continuous benefit subsequently also. So what the recent 5 years update of this particular trial says, which was presented a few months back in the October 2023 at the ISMO, that yes, it's results are consistently being shown and has passed the primary endpoint, that is the invasive disease-free survival. So the various side effects are also there, which also remain our concern. And the points which come always in our mind is that when we try to reduce the dose, is there similar efficacy in the adjuvant setup? And it has also been shown based on the various data that when you go beyond 150 to 100 milligram, probably their efficacy in the adjuvant setting remains almost the same. So at the 5 years, what this trial concludes, that is the patient who are at the high risk of the recurrence, invasive disease-free survival benefits continue to deepen further, and adverse events were reversible and manageable, and safety parameters remains almost same what the data previously being given about this trial. Now coming to second positive trial, that is the Natalie trial based on the ribociclib. So that's again the more or less similar overlapping indications of the parameters of the patient are there. But this trial doesn't talk only about the anatomical node positive patient. Obviously, the node positive patients are there, but even with stage 2 patients who are node negative, based on the various risk factors, these trials also include the other parameters. Now, this trial, because the drug schedule is 21 days rather than the continuous, and they have reduced the dose from the standard dose in the metastatic setting from the 600 coming down to the 400 milligram to improve the toxicity, and they have increased the duration of the exposure from the 2 years to the 3 years. So these are the two important parameters about this particular trial. So it is covering a broader population of the patient, not only the node positive patient. The drug is the 400 milligram, and it is 3 years exposure to this particular drug. Now, parameters, primary endpoint remains the same, that is the invasive disease-free survival. Again, this trial is showing the positive results. The anatomical stage-wise, if we try to analyze, both stage 2 patient and stage 3 patient are being benefited as far as the primary endpoint for the ribociclib is concerned. Obviously, the nodal status positive patient also remains benefited by this particular combination also. And so is the distant disease-free survival also. So coming to the overall survival, which always remains a sore point for the discussion, for the trials, and most of the time it remains the secondary endpoint. But we always try to talk that until there is the overall survival gain, probably it's not worth practicing it. So the data for the overall survival for this trial as on today remains immature. Larger data are required because to gain a 4 to 5%, which is being expected in the adjuvant setting, to further enhance the results, probably a longer follow-up is required. So adverse events and the other parameters, if we compare, this is the overlapping population, not exactly the same population. It's again the cross-trial comparison, the toxicity, the indication, inclusion criteria, they are little bit different. Adverse events for both these trials remain the concern. The individual drug adverse events are there. If you talk about the ribociclib, we see that the few liver toxicity are there to the tune of the 8.9%. Arthralgia is another concern with this particular drug. And the important 2 points which this particular trial, ribociclib-based trial, try to bring is the patient-related outcome and the health of the quality-related parameter. These 2 points are broadly missing in the abemaciclib-based clinical trial. So the physical functioning scale based on the quality of life parameters being studied, and this particular trial try to say that the health-related quality of the parameters and other patient-related outcome remains stable. So another question which comes as the validity of the surrogate endpoints. This is the point I am bringing for the discussion in front of all the who are participating today. That do we always concern the surrogate endpoints important for our clinical practice, like invasive disease-free survival, distant survival, patient-related outcome, health-related quality of parameters, overall survival. So that what trial says to get its approval or the positive result versus in the clinical practice may be little bit different. So partial overlapping indication of the two CDK4 inhibitors are there. So how wisely we can choose between the two for the individual patient depends on the many factors, that who will be benefited for the treatment in the given scenario, how much drug is needed, what are the potential downsides in terms of the safety as well as the tolerability. So these things we need to keep in the mind when we prescribe to the individual patient. So the choice between the two will depend on so many factors. Like if we talk about Adjuvant today, regulatory approval, which is more with the abemaciclib, drug access, depending on the cost factor, risk of the recurrence of the individual patient, long-term safety data or efficacy data, available safety profile, and obviously the patient preference based on the schedule and the toxicity profile. So many new points which are emerging, which are coming in my mind, the clinical scenario which we still need to answer when we prescribe this sort of the treatment. Is there still a need for the new adjuvant chemotherapy for the HR positive patient? Let's say the patient is stage 2 or stage 3, and you have done the upfront surgery, or you are thinking to do the neoadjuvant chemotherapy, and you are thinking that the patient can go for the adjuvant CDK4 inhibitor. So in that clinical scenario, what the role for the neoadjuvant, including adjuvant chemotherapy, will be there. Those patients who are the BRCA positive and high risk, so what can be the role for the individual drug like the adjuvant olaparib? What should be the sequence? What should be the preference? Patient-related and long-term safety. And do not forget that many of these patients, being the younger, they have not completed their family. So what can be the gonadal toxicity or the oncofertility issues? And important question which will be coming more and more in the future when you expose the drugs in the adjuvant setting, what role they will be playing in the metastatic setting if many of these patients will be having the relapse in spite of being exposed in the first line. So how the ISMO guidelines are helping us in this particular situation, that is, if you have the HR positive patient, if it is like luminal A-like picture, low risk, go ahead with only the single agent adjuvant endocrine therapy. But if the luminal patient, high risk patient, or luminal B-like of the patient, you have given neoadjuvant chemotherapy or adjuvant chemotherapy, and the patient is stage 3 or the high risk is stage 2. Depending on the germline BRCA testing and the availability of the information, if it is wild type or untested, go ahead with the aromatase, endocrine therapy along with the CDK4 inhibitor, that is the abemaciclib. If germline is mutated, stage 3 or the high risk stage 2 patient, not pathological CR, probably it's better to go for the olaparib. Now the point comes here for the discussion that both these positive trials, their period of the adjuvant may differ. Up to 6 months you can enroll, but the olaparib need to be given for the 1 year. So still you want to give them sequentially. Can the patient tolerate the toxicity of the olaparib in combination with the CDK4 inhibitor? So these are the still points we need to answer ourselves, and we need to see that are the new trials are going to give us these answers. With this thought process, I would like to complete the presentation. Thank you.
So thank you, sir. Sir, so there is a practical experience. Are you using, sir, upfrontly in this high-risk setting?
Yeah. So I'm still more in favor of the abemaciclib because of the regulatory approval. That is the reason for that. But 400 milligram of the ribociclib looks attractive because we all understand the toxicity profile with the 400 milligram is more manageable, more appealing, and it gives you the drug holiday period of 7 to 10 days also.
So, sir, do you feel that ECG abnormality with this ribociclib? Are you discomfortable with this ECG abnormality with this ribociclib?
Yeah, it's a concern. The moment it goes 45 to 46 milliseconds, at least my heart starts beating extra, and I start getting the premature ventricular contraction. It's a problem because the problem is there are a lot of drug interactions with the ribociclib. Okay. There are certain food restrictions also. Patient may be hypertensive, may be taking some drug, and this may lead, unfortunately, the sudden cardiac death.
Okay.
So
Sir,
that's a big concern. It is not the concern of the myocardial damage, which you can maintain sudden toxicity. The basic problem is the sudden cardiac death with the prolonged QTC.
sir, any concern of loose motion with this abemaciclib?
So that is manageable. You can reduce the dose, you can give the loperamide, you can educate the patient, dietary modification. So that is actually more you educate the patient, less will be the toxicity.
Sir, is there in future the use of this adjuvant CDK4 is expanding more and more in numbers?
Yes, yes, it will be obviously kind of the PAP program which they are offering, and the kind the maybe that in the near future when the ribociclib will be more accessible based on the cost factor, I think it will be increased. And
Sir,
if we look at the cost of the so many other drugs, I don't find any reason not to use in a given scenario of the patient. My criteria remain very simple. Stage 3 patient, they are eligible. Stage 2 patient, you try to find out in the real sense, are they really at the high risk? Do they deserve this sort of the 4 to 5% of the possible potential increment in their outcome?
sir, is there any age criteria to, deciding for this adjuvant CDK4? 40, 50,
So
30 or
probably
60?
beyond 65, I don't try to give it. But these
Okay.
patients
So,
have a lot of toxicity, which are difficult to manage. Support system always doesn't remain so accurate for the, let's say, 70 plus patient. This is a day-to-day problem.
okay,
I
okay.
usually try to avoid giving this sort of the counseling for the elderly person.
Okay. Thank you, sir. Thank you, sir, for this talk. Any query from Jitendra from your side? Your experience?
Uh, I found Abema as a very tough drug to give. Probably I'm in a learning phase to give Abema. But yes, definitely only the drug which is having approval in adjuvant setting is Abema. So we have only this thing which we can do.
So, thank you, sir.
And I find the BRCA as the more appealing marker because that's more like the definitive predictive marker.
Yeah.
And for CDK4, it's just based on the endocrine receptor expression only. So exact predictive marker is not there. So whenever you have the BRCA positive, I think that it's better to go for the PARP inhibitor rather than the CDK4 inhibitor.
So, thank you, sir, for your inputs and for nice talk and nice presentation.